uh, you can stop and say. Okay. Indra is from Andhra Pradesh. Okay. Okay. So this often they ask about the Tanner staging. 13-year-old girl presents with sparse pubic hair, breast buds. What is the standard stage of her development? Can anyone tell that? 3. Yeah. So this is a very commonly asked. It's a simple question. So you just have to learn the Tanner staging. Once you are sure, you can get the marks here. And they very often is the confusion is between the prepubertal and the B1 and the B2. So just remember the breastbud stage, the start of the puberty. So they are very much interested in the start of the puberty for girls, which is Thilarche, and the as it progresses B3, B4, B5. So remember the Tanner staging. Similarly for boys with regards to the genitalia, so G1 will be the prepubertal. So it will be like a child prepubertal G1. And the first step, even that they have asked, the earliest sign of puberty in a boy child is enlargement of the testis. For the girls, it is the thelarche. So that also they have asked questions related to that. And in G2, it is mainly the enlargement of the scrotum and the testis, and reddening and change of the texture of the scrotal skin. Whereas the enlargement of the penis in the lengthwise is G3, and G4 it is breadthwise, and G5 will be the adult size. Similarly, when you get the sparse hair, when the comment is sparse hair, then it will be PH2. Then if it is coarser hair, dark and coarser hair, then that will be PH3. Almost a adult type, but only the area covering will be less. It doesn't go to the medial aspect, then that will be PH4, and the PH5 will be the adult in the quantity and the type. Okay. So in this, they have asked questions of the order of the puberty also. So there, as you know that in boys, which one will come first, which is the first we discussed. Anyone wants to take? So it's the testicular enlargement. Yeah. So you can talk. Actually, I am not able to see the comments since I am sharing. You can voice out so that we can move on quickly. Anybody wants to participate, just voice out because I am unable to see the comments since I am sharing. Okay. Similarly, these two questions they have often asked where Tanner score coming early for axillary and pubic hair. So that will be the adrenarche. And sometimes they would have asked about a Tanner score of Thilarche coming earlier for the age. So that will be premature thelarche. So these questions they keep asking very, although it's easier, but you have to know. Similarly, a 11-year-old Egyptian girl with obvious blood in her uh, pants. Her Tanner stage is 1 alone. So breast and axillary Tanner stage is 1. And she is refusing for the local examination. So what might be the answer here? Yeah. But in puberty, you have a sequence going on. So you have first the thelarche, then you have the axillary hair going on. Then only finally you will have the menarche. But here the breast and axilla are in the stage 1. So whenever you have something like that, then it will be a local cause. So the cause will be local cause. So here local cause is, so it's definitely not menarche or precocious puberty. So whenever there is blood in the, just like a menarche, but your breast and axilla has not developed. So that sequence is not happening. So it's probably the local cause. So local cause, and in Egypt, there is the practice of mutilation. So female genital mutilation is the answer here. Okay.
Sir, what is the answer for the previous question, sir?
This one?
Yes, sir.
Yeah. So here tenor score 2 of axillary and pubic hair. So it has come earlier. So axillary and pubic hair denotes from the adrenal. So the
Yes.
diasulfate comes and causes the adrenarche. So it's a premature adrenarche. So that is the answer.
Sir,
And
the BP 9960 has got any significance, sir?
no, it's just they are just I think
For a
uh,
distraction only, right?
but if it is hypertension is there, then
Yes.
you have to keep thinking in terms of adrenal hyperplasia. So like,
I mean, if it was hypertension, then it could have been adrenal tumor, no, sir?
yeah, adrenal tumor. Yeah.
But
Yeah,
but
in the
central precocious central causes can also cause hypertension, no, sir?
no, central precocious, why should it cause hypertension?
Can it cause adrenal hyperplasia secondary to the increased hormones?
No, we generally denote adrenal hyperplasia as a congenital adrenal hyperplasia only. Okay. So,
I don't know, no, sir. This adrenal tumor, adrenal hyperplasia, and central precocious puberty are three separate things, no, sir. I was just
yeah,
wondering whether central pressure so adrenal tumor can probably cause hypertension. I was just asking, sir, whether the central
yeah.
precocious puberty, when that
I think
happens,
maybe
when there is more.
what you're saying is right. So, adrenal tumor, maybe that's why they have kept the hypertension. And in central precocious puberty, you will have all the stagings happening together. So the first one should be the thelarche, because for precocious puberty, the first stage of puberty will be thelarche. So had a thelarche been there, here it is stage 1 only. So we
Okay,
cannot
sir.
put,
Will when the hormones are high in central precocious puberty, will not that cause adrenal hyperplasia also? That was my doubt, sir.
yeah, it can happen. The size can increase, but we don't
But there won't be
count
any
it as,
hypertension, right?
we don't
That's what I believe.
count it as adrenal hyperplasia. It will not cause hypertension. Definitely.
That is. Thank you, sir. Okay, sir. Thank
Yeah. Okay. And this the for in task they will ask you the science behind. So they will be asking the basic science. They will give you a scenario and they will ask you the basic science behind it. So a 7-year-old girl presenting to the clinic and was found to have puberty, Tanner stages B3 and PH2. So which hormone initiates the puberty? So after giving the scenario, they will ask you which hormone initiates the puberty. So what will be the answer here? It is the GnRH pulse. So gonadotropin releasing hormone given as a pulse. So that is the cause for the puberty. Okay. So suppose someone has precocious puberty then what treatment we can use? So GnRH is causing puberty. So someone has precocious puberty, height is getting affected. So what treatment options are left?
So analogs can be given also.
GnRH,
GNRS analogs. Analogs.
yeah. So that thing we should understand. So there is, so when GnRH is given in a pulsatile manner, so it initiates the puberty. But once you give it as a continuous exposure as analogs, it's going to suppress the puberty. So for precocious puberty also, we give GnRH analogs. Okay, so next, something related to the bone physiology. A 14-month-old baby presents with wrist swelling. Laboratory investigations show the following. So calcium is on the lower side, phosphate is on the lower side, alkaline phosphatase is elevated. So what is the most likely diagnosis?
Is it vitamin D deficiency, sir?
Yeah. So vitamin D deficiency. So why not the other options? How about parathyroid hormone? How will it be?
I'm not sure, but I think alkaline phosphatase may not be elevated. I don't know, sir. I'm sorry.
Yeah. So good attempt. So it is rickets. It's a good option. So here this tabular column. So the Lizar book, I have taken most of the references from the Lizar's illustrated textbook of pediatrics, because that is the book which we should prepare for the FOP and TAS. So this table will help you in analyzing different causes. Okay. So we all know that vitamin D deficiency, calcium will be low, phosphate will be low, and any rickets, alkaline phosphatase will be elevated. So if a rickets scenario is there, alkaline phosphatase will be elevated. And secondarily, the parathormone will also be elevated. So in vitamin D deficiency, so alkaline phosphatase will be definitely elevated and parathormone will be elevated. With regards to calcium and phosphate, to start with, phosphate can be, remember, it can be normal. Both calcium and phosphate can be normal. So that scenario will be there. Initially, the phosphate will be low, then followed by calcium will be low. So vitamin D deficiency to start with, calcium can be normal. So that's an important point we should keep in mind. With regards to parathormone, we should understand that calcium and phosphorus will go in the opposite direction. So if you have a scenario where calcium is low, phosphate is high, then that is due to parathormone. Or if calcium is high and phosphate is low, then that is due to parathormone excess. And remember, in this tabular column, the alkaline phosphatase is not elevated with regards to the parathormone related disorders. So only the rickets you have the elevated alkaline phosphatase. Okay. And how will be in pseudo hypoparathyroidism? Can anyone tell? So in pseudo hypoparathyroidism, it behaves like hypoparathyroidism. So calcium will be low, phosphate will be high. But when you look into the parathormone, it will be elevated. So that's why we tell it as it behaves like hypoparathyroidism. So it's hypoparathyroidism, but it's not hypoparathyroidism because parathormone is elevated. So what might be the reason here? Why is it behaving like this pseudo hypoparathyroidism? Because of the receptor issue. So probably the receptor resistance is there, and that's why we get the pseudo hypoparathyroidism. Okay. Okay. So now go through this scenario, similar scenario. A child presented with the following laboratory features. So vitamin D is less than 17, so which is less than the 25, the optimal 25, it's less. Calcium is on the lower side, 2. Phosphorus is a bit on the higher side of the normal, 2.1. So you can take it as normal also. So calcium is low, phosphate can be a bit normal or on the higher side. Alkaline phosphatase is elevated. So it is alkaline phosphatase is elevated and parathormone is low. So which supplement is the most appropriate? So here vitamin D is low, alkaline phosphatase is elevated. So looks like crickets. Calcium is low and we said phosphorus can be normal also. So which supplement is most appropriate? Who wants to try?
Vitamin D.
So vitamin D in the treatment dose. But the question is it the vitamin D which is the 20, 25, the regular vitamin D which we give, or you need the active vitamin D, which is 1,25,
125 hydroxy.
which is calcitriol. You want to give calcitriol or the regular vitamin D?
Regular vitamin D.
Okay, regular vitamin
అన్నాడు కదండి నిన్నే ఏమంటాడు నిన్ను మేస్త్రి నిన్ను మేస్త్రి ఏమంటాడు శిల్పాడు
Okay. So here in Lizar, there is a very nice diagram. So you go through that. It's nicely written how the calcium homeostasis goes through. So the parathormone, what it does is it acts on the kidney. It does three jobs. It acts on the kidney and causes calcium reabsorption. It acts on the bone and it mobilizes the calcium from the bone and thereby causing the calcium excess. So directly it acts on the calcium. It acts on the kidney to cause the reabsorption of the calcium. So these two jobs. And also what it does is it converts the 25 hydroxy vitamin D to active vitamin D, 1,25 hydroxy vitamin D. So active vitamin D is formed by the parathormone. So parathormone is needed for conversion of the 25 hydroxy calciferol to 1,25 hydroxy calciferol, which is the calcitriol. So for calcitriol formation, the parathormone is important. And this active vitamin D is going to act on the gut to cause the reabsorption of the calcium and the phosphorus. And the blood levels of calcium, if it is low, it is going to stimulate the parathormone to secrete more. So whenever calcium is low, it will stimulate the parathormone to secrete more parathormone. But remember, phosphorus is not a stimulus for parathormone. And that's why in hypophosphatemic rickets, parathormone will not be elevated. Because in hypophosphatemic rickets, phosphorus is low and it is not going to stimulate the parathormone. Okay. So we have to understand that parathormone is important for conversion of 25 hydroxy calciferol to 1,25 dihydroxy calciferol, which is the calcitriol. If parathormone is not there, this is not going to happen. So now you go to the scenario. In this scenario, a small important clue is written that parathyroid hormone is low. So now you tell me, even though it is rickets, even though vitamin D is low, even though alkaline phosphatase is elevated, so vitamin D is low, you usually give vitamin D, the regular vitamin D. But since parathormone is low, this vitamin D is not going to get converted to the calcitriol. So now you tell me what you should supplement when parathormone is low. Who wants to take? I think the answer is obvious, right? Anybody has any doubts? It has to be calcitriol. Okay. Dr. Sadia said that rightly. So the calcitriol has to be given because parathormone is low, so you are not going to get the active vitamin D. Okay, you use the same principles for this, so you will answer. So this is a question for the TAS. So what is the direct action of the parathyroid hormone? So now we discuss, so now you can understand. So what is the direct action of the parathormone? So remember that it doesn't have a direct action on the gut. Parathyroid hormone doesn't have a direct action on the gut. It is the vitamin D which is formed is going to act on the gut. So increase the calcium reabsorption from the gut is going to be wrong. Increase the phosphorus reabsorption from the kidney, it's going to be wrong because it doesn't cause the reabsorption of phosphorus. It's going to excrete the phosphorus. Increase the calcium excretion through the kidney, that's also wrong. It actually promotes the reabsorption of calcium through the kidney. Activation of 1-alpha hydroxylase in the kidneys. So do you all agree that parathormone main action is the activation of 1-alpha hydroxylase and thereby converting the 25 hydroxy calciferol to 1,25 hydroxy calciferol. Okay. So now you use the same picture to answer this question. Let's see who answers it. A patient with chronic kidney disease presents with pathological fractures and osteopenia. So there is pathological fractures and osteopenia. So what is the most likely cause here? So what is happening here? What will happen to the parathyroid hormone? What will happen to the vitamin D? So who wants to take it?
Hyperparathyroidism and low 125 vitamin D.
Hyper or hypo, doctor?
Option A, hyperparathyroidism and low
Low
125 vitamin D.
1,25 vitamin D. Yeah. Yeah, doctor. That's a good answer. So we should understand this again. So now here the kidney is damaged. So once kidney is damaged, so our 1,25 vitamin D will be less. So that's why it's going to be low 1,25 vitamin D. And since 1,25 vitamin D is less, reabsorption of calcium from the gut is going to be less. So the calcium in the blood is going to be low. So low calcium is going to be a stimulus for the parathormone. So parathormone is going to increase. So it's a secondary hyperparathyroidism along with low 1,25 vitamin D. So good. Thank you, doctor. Thank you. Okay. So now this very commonly they ask you a 14-year-old girl presents with decreased activity in gymnastics, deterioration in school performance, weight gain, and scanty periods. So what is the most likely diagnosis? So you can say, doctor. It's an easier one only. So here, most important is when they talk about deteriorating school performance, which is something related to the intelligence. Then weight gain, so weight gain, and then affection on the scanty periods. So you should think in terms of
Hypothyroidism.
yeah, hypothyroidism. So hypothyroidism is very important. So they ask you almost all the questions you are able to based on your knowledge you will be able to answer. Just you have to apply. So they usually give us case scenarios. Okay. So here the girl child you have to understand the symptoms. Mostly you will get the acquired hypothyroidism only. Congenital hypothyroidism usually we have a newborn screening, so you might not get a congenital hypothyroidism. So acquired hypothyroidism only. So the constipation, amenorrhea, deterioration in the schoolwork, so pubertal disorders, short stature. So something mostly these are the symptoms they presently. Okay. Okay. So here a female infant with hypothyroidism was prescribed levothyroxine at 25 microgram. Instead, it was 75 microgram was given. Instead of 25, 75 microgram was given. So, which of the following is most likely clinical evidence of toxicity? So, which is the most probably the clinical evidence of toxicity?
Poor sleep.
Poor sleep. No? Okay. But so just remember uh, thyrotoxicosis and Graves. So, what comes in your mind whenever you think of Graves' disease, thyrotoxicosis?
Cold
Tachycardia.
intolerance.
Tachycardia. Yeah, tachycardia. Yeah, I think all these are correct only. Poor sleep, diarrhea, cold intolerance, wrong. Weight gain, wrong. But other things, the poor sleep are all very close. But I think the tachycardia. Tachycardia is the most important way you monitor the thyrotoxicosis. Okay, so before going, we will just go through the hyperthyroidism few points. So, commonest is Graves' disease, which is an antibody mediated. So, what is the antibody? It is the TSH receptor antibody. We call that as the TRAB. So, the TRAB antibody is very significant for the Graves' disease. Similarly, autoimmune thyroiditis also can cause. So, your anti-TPO antibodies in autoimmune thyroiditis, that is the Hashimoto's thyroiditis. Initially, this autoimmune, initially because of the damage, they have some hyperthyroidism features, and then there will be a hypothyroidism. So, Graves' disease, straight away TSH receptor gets stimulated. So, TSH receptor stimulating antibody is there, receptor antibody. So that causes hyperthyroidism straight away. Autoimmune, the anti-TPO antibody is going to damage the thyroid, give out the thyroid hormone and cause some initial hyperthyroidism and then hypothyroidism. Okay. So the standard will be TSH will be low and T3, T4 will be raised. So the initial tachycardia and tremor, so that is the most important side effect. So we give the beta blockers for that. And for the hyperthyroidism, we choose carbimazole and propylthiouracil. Usually, propylthiouracil is reserved only for the pregnancy, mostly because of the risk of teratogenicity for carbimazole. So, carbimazole is the choice for hyperthyroidism. And we should understand the most important side effect is neutropenia. So, if they give a scenario of child presenting with sore throat after on antithyroid drugs, then you should be aware that you are dealing with neutropenia. You give these drugs for 2 years around for treatment, and after that you stop. But mostly two-thirds will relapse, and the only option left will be either radioactive iodine ablation or surgery. So either of the one you have to do. There is a concept called neonatal Graves or neonatal hyperthyroidism, where maternal antibody gets transferred, maternal TRAB gets transferred, and only for a momentary 2 months they will be having hyperthyroidism. Okay. Okay, doctor. So now you look into this and try to find out. A female child drinks 10 cups of juice daily and presents with polyuria, polydipsia. Glucose and ketones are negative. Protein is trace. RBC is trace. Leukocytes 1 plus. Nitrates negative. So the child is active with an unremarkable examination. So what is the most likely diagnosis? So who wants to take this?
Habitual polydipsia.
Yeah. So habitual polydipsia. So on what basis you are saying habitual polydipsia?
A child is not dehydrated, sir.
Yeah, very good. So if the child is dehydrated, in spite of the polydipsia, if still the child is dehydrated, then think in terms of diabetes insipidus. And why not diabetes mellitus? So your urine glucose and ketones are negative. So here urine glucose and ketones are negative, and polyuria polydipsia is there. Chances are that it can be diabetes insipidus, but the issue is the child is active with no unremarkable. So usually diabetes insipidus, even though they have polydipsia for the polyuria, still they might be a bit dehydrated, failure to thrive might be there. So those things are there. So it's here mostly because of the child taking the juice daily. So how are you going to prove that this is habitual polydipsia? So how are you going to prove that this is habitual polydipsia? So in a specialist center, we can go for the water deprivation test. But to start with, in LISAR, it's given that restrict the child's intake of juices in between the meals. Restrict the child's intake of flavored drinks, beverages in between meals. So that will itself will reduce the polyuria and polydipsia. So to your level as an ST3, I think do not choose the water deprivation test to start with. So first to start with will be restricting the uh, juices in between meals. First you do that, and still the polyuria is persisting, then you go for the uh, water deprivation test in specialist center, because the risk of serious problems are there when you go for water deprivation. The hyponatremia can cause serious problems. Okay, so this one. So I will just read. So they have given diabetes mellitus. They keep asking again and again. It's a very important core topic of endocrinology. Almost half the questions from endocrinology will come from diabetes mellitus. So here is a 10-year-old child who has a well-controlled sugar levels for the past 5 years. So what is the most important thing to tell this family? I think here I just kept it to talk about the follow-up care. So he should be checked for diabetic complications regularly. So that's what you need to convey to the parents. For someone who has been taking care of the child very well for the past 5 years, so you not talk about the diet as well as insulin. So you have to talk about the complications. So they need to get screened for the complications. So here is the criteria. So most of the screening to remember starts from 12 years of age. Then it will be annual checkup. So be it blood pressure, then microalbuminuria or eye checkup. So all this start from 12 years. It is done annually. So every year you have to do. And some other complications are like the lipoatrophy. So when you do the non-rotation of the insulin sites, it can go for lipoatrophy or lipohypertrophy. So the target range for any diabetic is 6.5 percentage, which is ideal. Usually kids don't reach the target of 6.5 percentage, but if you miss that, chances of long-term complications starts happening. Okay. So this is a very simpler question, straightforward question which you can answer. So for tall, whenever you talk about a tall 14-year-old boy present with underdeveloped secondary sexual characteristics and mild learning difficulties, his reports being teased at school, which of the following is the most likely diagnosis? Who wants to take an easier?
47XX.
So it's a Klinefelter's disease. So
Excellent.
suppose you have a girl child who is short, then what will be in your mind? Short child. Similarly with pubertal delay.
Turner syndrome.
Okay, so these two, they keep asking again and again. So simpler only, but you should keep. So now this is a a bit quite tricky. So a newborn presents with ambiguous genitalia and severe hypospadiasis. The parents are eager to assign a name. So what is the most appropriate recommendation regarding naming the baby? So ambiguous genitalia, severe hypospadiasis. So what recommendation regarding naming the baby will you choose? Anyone can answer.
Sir. Tell the parents that the gender is undetermined. Now,
And to delay the name until the gender
the gender has been confirmed later.
yeah. Okay. And if this is not there, a close thing will be to tell the parents that gender can be assigned after chromosomal analysis. So sometimes in one of the questions also they have asked. So their chromosomal analysis is the most important investigation that needs to be ordered. So what will be the next step? I think they asked this question. So what will be your next step in managing a child with ambiguous genitalia? So that will be immediate will be the chromosomal analysis. So you need to know the genetic sex of the child. But I think the final answer which you said is more apt in this scenario where you have to say that we have to delay the name until the gender has been confirmed, and that the team of experts are going to tell. Okay. So DSD regarding it's a medical emergency. If the genitalia are abnormal, the infant sex must not be assigned until the results are available from a detailed assessment. So the team has to do a detailed assessment. Only then the sex can be assigned. Even birth registration must be delayed until this has been completed. What is the most important next step will be to do the microarray or the karyotyping. We need to know what is the genetic sex of the child, microarray or karyotype. Also do the sex hormone levels and try to find out if gonads and internal structures. Based on that you have to arrive at the diagnosis. So you can do an ultrasound to look for the Mullerian structures as well as the ovary and the gonads. And if you're not sure whether what type of gonad is there, you can even go for a laparoscopic imaging and biopsy of the internal structures if necessary. Definitive surgery. Definitive surgery means if total change in the sex, such surgeries has to be delayed.
ಮಲ್ಕೊಂಬಿಡು ಹೋಗು ಹೋಗು ಮಲ್ಕೊಂಬಿಡು ಈಗ ನಾನು ದಾರ್ಯಾಗ ಓಡಾಡಕ್ ಹೋಗ್ಬಿಡ್ತೀನಿ ಹೋಗ್ ಜಲ್ದಿ.
Okay. So definitive surgery may be delayed even till the child becomes grown up. So if you want to do a major surgery, major definitive surgery, better you have to wait till the child grows up. Okay. So the final crux is do not guess the infant sex. You have to wait. And the most common disorder of sexual development in female is what? What is the most common cause for ambiguous genitalia in a female child? So that also they keep asking again and again. They keep touching this concept again and again. So what is the commonest cause for ambiguous genitalia in a female child?
21 hydroxylase deficiency.
So it's the congenital adrenal hyperplasia. So they are more concentrating on the congenital adrenal hyperplasia, especially the 21 hydroxylase deficiency. Okay. So this is a girl, 11-year-old obese, BMI 31, presented with polyuria, polydipsia, and weight loss. There is family history of diabetes. What investigation to do next? So you have a 11-year-old obese presenting with polyuria, polydipsia, and weight loss. So what investigation will you do next? Anyone can take. Indra, Dr. Indra.
Glucose tolerance test, sir.
Okay, so that's what it's a very subtle thing. No, it looks like simple, but it's a very subtle change. And FOP and TAS, that's the main problem. Everything looks very, very close thing. So, what is glucose tolerance test? So, you are going to do a fasting sugar, then you are going to give a glucose load. Then, after 2 hours, you are going to check the sugar. Okay, and this has to be done. Maybe fasting means I think you have to go to the next day. Okay, but what if this child ends up with a decay? It's possible, na? And what is the cause for the polyuria and polydipsia? So it means that the sugar is high. It's an osmotic cause, no? So because the sugar is high, that's why you are having polyuria and polydipsia. So if you do sugar now itself, your sugar will be elevated only. So what will be the choice now? So any point of time you do, it's going to be high only because it's already there is polyuria and polydipsia. So you need not wait for a fasting, then give a glucose load and then check the sugar. So that will be done when you are confused. So when you want to differentiate between type 2 without much symptoms, type 2 is there without much symptoms, you are confused. So then you can do the glucose tolerance test. But here I think the random blood glucose, a simple capillary random blood glucose is more than enough to point the diagnosis. Okay. So remember about the diabetes. So you have the polyuria, polydipsia, weight loss. So in a symptomatic child, so that's what in a symptomatic child, the random blood glucose is more than enough and it has to be more than 11.1 millimoles per liter plus associated symptoms like glycosuria and ketosis. So random blood glucose more than 11.1, which is 200 milligrams per liter. So 200 milligrams or 11.1. Can someone tell the conversion between millimoles to milligrams? How much we are going to multiply? Anybody wants to tell? So it is 18. So you multiply it by 18. And for a quick multiplication, you multiply by 20 so that you have some idea where you are because we are more tuned into milligram and here it comes in millimoles. So you multiply it by 18 for sugar. So for a quick, you just multiply by 20, you have some idea. So somewhere around 200. So 200, when the random blood glucose is 200 or 11.1 millimoles along with glycosuria and ketosis. If you are doing a fasting blood glucose, it is 126 milligram. So if you convert into millimoles, it's going to be 7 millimoles per liter. Or if you do only a HbA1c, if it is more than 6.5 percentage, then again it's going to be diabetes. So the definition. So these are the definitions for diabetes. Then if you're going to do a oral glucose tolerance test, again it's the same, more than 11.1 millimoles per liter with symptoms of hyperglycemia. So in type 2 diabetes, where there is a family history, obese child with acanthosis, then it might be a bit difficult. So there you do the glucose tolerance test to differentiate between type 1 and type 2 diabetes. Okay. So any doubts in this? So remember this magic value of random blood sugar 11.1, fasting blood sugar 7, and HbA1c of 6.1 percentage. Now you tell me the answer. Who wants to tell? So here is a boy with obesity and acanthosis nigricans has a family history of diabetes, father and uncle. Which of the following is most suggestive of diabetes? Fasting blood glucose of 7.8, HbA1c of 5.6, postprandial glucose after 2 hours it is 9, and random blood glucose it is 7.8. So who wants to answer? Dr. Indra, are you there?
Sir, A, sir, fasting
Yeah.
blood
So
glucose.
we studied, na? So 7, na? We took the criteria 7. So it is above 7. So it is the choice. Fasting blood glucose above 7, or postprandial above 11, or random blood glucose above 11, or HbA1c above 6.5%. So this all will suggest the diabetic range. Okay. Okay. So now you have a known diabetes mellitus 1 interested in football game. What is your advice regarding exercise to his family? To his family, what will be your advice? Can anyone tell? So is it the reduce the time of exercise, or take an extra carbohydrate diet? And what should be the random blood glucose level when you want to take the extra carbohydrate source? Anybody wants to guess? Okay, I will do it for you so you can again come back. So you have the challenges in management. This is also taken from the lizards. So during illness, it's a challenge. So remember that during illness, insulin should always be continued. So do not stop insulin at any cost, even during illness, because DKA is going to precipitate only during the illness. So you are going to uh, monitor what are the food he is taking. You're going to monitor regularly the glucose and ketone levels during illness, and you have to adjust the rapid acting insulin accordingly. So maybe you have to give extra dose of rapid acting insulin if the ketones are going to be positive, or if the glucose is going to go down, you have to reduce down the rapid acting insulin. Similarly, in exercise, if you are going to do a vigorous exercise like a marathon, etc., it's going to be a vigorous exercise, then you have to do both. You have to decrease the insulin dose as well as take an extra carbohydrate. You have to take extra carbohydrate for that. Okay. But if it is going to be a regular school exercise, then you just decrease the insulin, that is more than enough. Okay. And this guideline is only that for the MCQ. Before exercise, if the blood glucose is 7 millimoles per liter and less, which is nothing but 7 millimoles, like almost 130, 126. So if the blood glucose is less than 126, then you have to take an extra carbohydrate. So if you are planning an exercise and your blood sugar is less than 126, which is 7 millimoles per liter, you have to take an extra carbohydrate. Okay. And in adolescent, we know that because of the insulin resistance, we need an extra insulin. Many times it increases up to, usually initially it will be only 0.5 to 1 unit per kg per day requirement. So during adolescence, the requirement of insulin increases up to 2 units per kg per day. So now you tell me what is the answer for this. So we have to take an extra carbohydrate if the blood glucose level is less than 7. So once it becomes less than 7, you have to take an extra carbohydrate. Okay. So now DKA is a topic which they keep asking again and again. So can someone tell the answer? A 14-year-old child presents with diabetic ketoacidosis. Child has tachycardia, capillary refilling time is 2 seconds. Severe dehydration is there. So what is the most appropriate maintenance fluid? So what is the maintenance fluid which you are going to choose? So who wants to try out this? Dr. Sanjay. Active participation.
E, sir.
Yeah. So it's the normal saline. It's not the half normal saline, it is the normal saline. Plus we add the potassium. And most important, we are not going to start with dextrose. We are not going to add dextrose to start with. Okay. So this guidelines, DKA is one topic. Definitely you're going to get at least one or two questions. One question definitely from DKA they will be asking. So you have to read the pediatric guidelines, the partners guidelines given by the UK. Okay, so you read the UK guidelines. So I have taken one picture from Lizar so that it can be a very useful revision. From this chart, definitely they are asking one question. So make sure that you are thorough with it. So try to categorize the mild DKA, moderate DKA, severe DKA. So that is based on the pH. So more than 7.2 will be your mild DKA, and moderate DKA is 7.1 to 7.2, and less than 7.1 is your severe DKA. So remember, less than 7.1 is the severe DKA, and more than 7.2 is your mild DKA. So that is the most important. Another one point, they will always check you that with this much acidosis, diabetic ketoacidosis, we don't give bicarbonate to correct the acidosis. I think these are very core points. So they will check by giving MCQs. So we are not going to give bicarbonate at all to correct the acidosis to start with. Okay. And if the child is shocked, then we are going to give a bolus, 20 ml per kg of saline bolus. If not in shock, then we are going to give the 10 ml per kg of bolus over a period of 1 hour. Okay, so that is going to be saline. Then what will be the dehydration correction? They might ask you. Less than 7.1 is 10% dehydration. More than 7.2 will be the 5% dehydration. Okay, and this dehydration correction will be over for 48 hours. Then this is the question which they asked you, the maintenance fluid. So it's going to be normal saline plus potassium chloride, 20 millimoles of potassium chloride in every 500 ml bag. Okay, and make sure that the child has passed the urine. Only after the fluid correction we go for the, after 1 hour of fluid correction, we go for the insulin infusion, which is 0.05 units per kg per hour. Then you add the sugar as the blood sugar starts coming down. So you give 5% dextrose when it becomes less than 14 millimoles per liter. Okay. So 5% dextrose is given when it becomes less than 14, which is almost 250, somewhere around 250. You are supposed to add 5% dextrose. Then you're going to monitor the potassium, most important. Then sodium. Okay. And depending upon the conscious, this is another scenario they will often ask you. You are treating a DKA child and suddenly the child goes into lower consciousness level. So what are you going to do if the child consciousness comes down, GCS comes down? So what two things will you do? Who wants to take? So you're correcting a child with DKA, suddenly the sensorium is down. So what two things should be in your mind?
Cerebral edema, sir, because of too much
Yeah.
of fluid and too
Yeah.
rapid correction.
Yeah, cerebral edema should be in your mind. And also before cerebral edema, you are supposed to make sure that there is no hypoglycemia. So you have to rule out hypoglycemia, then cerebral edema. And for the cerebral edema, you give immediately the 3 ml per kg of 3% saline. So this part is very important. Okay. And you're not going to stop the insulin if the sugar is coming down. You have to keep continuing the insulin infusion. You can add more strength of glucose, but till the ketosis resolves, till the acidosis resolves, you have to keep continuing the insulin. So that is important. Okay, so now we move on to another point. A 10-year-old child with a known case of diabetes mellitus presents with persistent vomiting, blood ketones are positive, random blood sugar is 2.3 millimoles per liter. So what is the most appropriate next step in the management? Child, known case of diabetes mellitus. This also they often keep asking you. So either diabetic ketoacidosis or this scenario. So what are you going to do, doctor? Let's check. So what is this scenario actually? This is the scenario of. So what is 2.3 millimoles per liter of sugar?
Hypoglycemia, sir.
Yeah. So 2.3 into 20. If you multiply by 20, it's 40. So somewhere around 40 and less than 40. So the sugar is less. So the most important step. So what will be your next important step? So often they ask you, what will be your next step? In diabetic ketoacidosis, sugar is low. So what will be your next important step?
Dextrose, 10% dextrose, 2 ml per kg.
Yeah, 10% dextrose, 2 ml per kg. Good, Dr. Sanjeev. So why you choose dextrose 10%, 2 ml per kg against the oral 20 ml glucose or the sugar tablets like that? So why not we go with 20 ml of syrup glucose? So I think if you go through this hypoglycemia uh, revision, you will understand. Okay. So what is hypoglycemia? So that you need to first remember. So blood sugar level less than 4 millimoles per liter. So 4 into 20 will be 80, so somewhere around 75, 70, no? Somewhere around 70. So less than 4 millimoles per liter is hypoglycemia. So for diabetic alone, this value is taken. So 4 millimoles per liter in diabetics is considered as hypoglycemia. So they will have the sweatiness, fainting, dizzy, tremors, etc. And if it keeps continuing, they will end up with neuro symptoms, fits and loss of consciousness. So while deciding the type of treatment, you have to look into the sensorium. If the sensorium is good, GCS is more than 8, then you can go for the oral choices, glucose tablet, sugary drink, or oral glucose gel which can be kept in the buccal mucosa in an uncooperative child. If the glucose is less than 8, then the child will not be in a position to take it orally. So then you have to give the IV. Ideal will be IV, but for that the child should be in the hospital. So then you, as you said, the 2 ml per kg of 10% dextrose can be given. If you are not in the hospital setting, in the school setting, and the child is drowsy, the child is unable to take the oral glucose gel, then you can go for the IM glucagon. Okay. So now you look into this. So here sugar is low. And one more point is child is vomiting out. Child is persistently vomiting. So there also you can step in and try instead of giving oral because the child is persistently vomiting. So you can go for the IV option. So dextrose 10%, 2 ml per kg can be given. Similarly for this, now what will be your choice? So look into this answer, understand and try to tell.
Sir,
So before you,
once keep slide number 37.
doctor?
Slide number 37. Please show me the once again.
You want to see? Yeah. This is the definition for diabetic ketoacidosis. You
Okay,
can
sir. Thank you.
have a look
Thank
into it. We'll share the recording, doctor. Don't worry. Okay. So So anything when the sugar is more than 200, ketones are more than 3, and your pH is less than 7.3, and bicarbonate is less than 15. These are all the criteria for the diabetic ketoacidosis. Okay, what all investigation will you be doing? So in addition, you will be checking for the T wave changes for potassium or ECG. Try to find out the cause for the decay. Any infection is there or not, so that we are going to check. Okay.
Mhm.
Okay.
Sir,
So
where it is
now,
keeping in, sir, can
doctor,
also small.
tell
Where
me.
it is keeping in the recording, sir? This available in
Recording, na? We will share in the WhatsApp group, doctor. In YouTube, we will upload and we will share it. Okay.
YouTube. So,
We will
sir,
share you in the YouTube.
I am new member, sir. So I
Uh,
don't know the channel, वगैरह. I
yeah,
got the
yeah.
link through.
You are in the WhatsApp group, doctor?
No, sir, no, sir. That's why I'm
Okay.
asking. In YouTube channel name, कौन सी?
Yeah, it is a target MRCPCH. Target
Okay, sir. Thank you, sir.
MRCPCH. Okay, I will tell my number. You can message me. Okay.
Okay, sir. Thank you, sir. Sorry to disturb, sir.
Thank you.
Continue.
No problem. So now you tell this scenario. So here the random blood type 1 diabetes mellitus. So anything less than 4 is hypoglycemia. So here it is 2 millimoles per liter. So what is the best immediate management in the school setting? And the child is drowsy actually. So which means that GCS is less than 8. So in the school setting, what will be your choice now?
I am glucagon.
Yeah. So that subtle difference you have to understand. So here the child is drowsy. So you cannot give the oral glucose gel, and you cannot give IV also because the child is not in the hospital setting. So in the school setting, you can go for the IM glucagon. Okay. Had the child been in a good sensorium, then you can give the sugary fluid, glucose tablets, glucose gel, like that. Okay. So this is what we discussed. Okay. So this one, this is a scenario of hypoglycemia in the newborn period. So the child, baby is presenting with hypoglycemia. The baby needed a higher amount of IV fluids, 10% dextrose, 150 ml per kg per day. Then they gradually tapered, transition to enteral feed. But before discharge, again the baby developed hypoglycemia. So which means that we have to investigate for hypoglycemia. So in this question, the answer is, so whenever the child has persistent hypoglycemia, then you have to evaluate the child for hypoglycemia. So this is the points about hypoglycemia. Remember that in diabetes, the definition for hypoglycemia was 4 millimoles per liter, but in newborn, in non-diabetics, it is 2.6 millimoles per liter, which if we multiply, it will be around that 40. It will come to around 40. So 2.5 into 20 will be, so that will be around the 40 milligram. But for diabetic, it is somewhere around 4, which is coming to 70. Okay. We all know that less than 48 hours, they are prone for diabetes, especially the GDM babies and SGA babies are prone for the hypoglycemia. If it is persisting beyond 48 hours, then only we need to be careful. We should understand that the most common is persistent hypoglycemic hyperinsulinism of infancy. So hyperinsulinism is the cause, one of the most important cause. How will be the child biochemically? Will ketones be present in hyperinsulinism? So it's a cause of non-ketotic hypoglycemia. So remember that hyperinsulinemia is an important cause for non-ketotic hypoglycemia. So when you get a scenario where sugar is low and ketones are low, then remember it's probably the two conditions only. So one is hyperinsulinism. Can anyone tell the another condition which can present with non-ketotic hypoglycemia? So there are two conditions. Most importantly, there are only two conditions. So one is hyperinsulinism. It causes
IEM.
not. The other one is
Uh, IEM, sir.
yeah. In IEM, which one? Right. Not all.
Fatty.
Yeah.
Not sure, sir. Not sure.
Yeah. Correct only. Correct only. So the fatty acid oxidation disorders. So in fatty acid oxidation disorders, ketones will not be produced. So that is also a cause for, because finally ketones needs to be produced. So in fatty acid oxidation defect, ketone will not be produced. So two conditions where ketones, non-ketotic hypoglycemia is hyperinsulinism and your fatty acid oxidation defect. And for fatty acid oxidation defect, we do the acyl-carnitine profile. We will be doing the acyl-carnitine profile. And in this hyperinsulinism, how will you, what clue will be there is the child will be needing a higher concentration of glucose solution. So whenever you have a child who needs higher concentration of glucose solution, it means that the child is having hyperinsulinism. It doesn't mean that the child is having growth hormone deficiency or cortisol deficiency, because usually they don't need a higher glucose solution. But hyperinsulinism will be needing a higher concentration. And we usually treat with diazoxide, and sometimes you have to go for surgery of the whole pancreas because of the hyperinsulinism. The second group is the ketotic hypoglycemia. In ketotic, it is because gluconeogenesis is not happening. So you have to keep taking feeds again and again. You have to avoid the starvation. You have to reduce down the starvation. So one important cause for ketotic hypoglycemia where hepatomegaly is there. So remember the glycogen storage disorder. So in glycogen storage disorder, they will give you a clue of hepatomegaly. Then you should understand the concept of critical sample. So whenever sugar is low, it is that time you have to take the investigation. So that time you take the blood sample. So that is called the critical sample. You check the what is happening to the insulin, C-peptide, ketones, growth hormone, and cortisol, and also the acyl-carnitine profile, and for the IEM screening. So all the lactate, ammonia, amino acids. So all these are taken from the critical sample. So you take the critical sample and you do the insulin, you do the growth hormone, you do the cortisol, you check the ketones, you do the acyl-carnitine profile, and you do the IEM screening. Okay. And as we discussed in hypoglycemia, the treatment is 2 ml per kg of 10% dextrose. And yeah. So now moving on to this question, to something related to the growth hormone. So who wants to take this? So you have a 13-year-old boy presented with the concern of short stature. His bone age is 10 years. He has a good school performance. His parents' height is 25 to 50th centile. He has prepubertal signs. Weight centile on the 9th centile. What to do next? What to do next? So many times they will ask you this only. They might not ask you the best. They will ask you what to do the next. So as per protocol, what to do the next. It's not the what is the best investigation or what is the investigation that will clinch the diagnosis. They're not asking that. They're asking what to do the next. So who wants to take? So here the bone age is reduced than the chronological age. So 13 years and bone age is very much reduced. Parents are of the normal range, 25th to the 50th centile. And he has only prepubertal signs. He has not yet attained the puberty. His weight centile is above the normalcy, but the height centile is less. He is probably short. So now what will be in your mind? Dr. Indra? First of all, what's in your mind actually here? Someone whose bone age is delayed, who is short compared to the weight. Weight looks a bit normal, but height is affected. And parents are of normal height.
Sir, when bone age is delayed, shouldn't it be an endocrine cause, sir?
Yes, sir.
Yeah. So we should keep the endocrine cause in this mind. So whenever the bone age is delayed and height is more affected than the weight. If weight is more affected, then we think in terms of nutritional or some systemic infections where weight will be more affected. But here, height is more affected, bone age is more affected, and parents are of the normal height. So you think in terms of the endocrine. But here, still, the question is not over. What to do next? So, which hormone you will try to rule out in the initial phase, and which one might be a bit difficult to do? So, based on
Thyroid function test initially, sir.
TFT, yeah.
yeah, so that is the crux here. So, straight away it looks like a hormonal, and whenever you have a short stature, you tend to touch the growth hormone. But what to do next means it is not that easier to do a growth hormone stimulation test. You need a specialist opinion. You give insulin, hypoglycemia happens. You need to monitor. So you have to take serial samples. So it's not that easy to do the growth hormone stimulation test. So what to do next? So try to rule out whichever is easier to treat, easier to pick up. So then that will be the thyroid function test. So if you go into Lizar's illustrated book also, no? So if you look into the list of investigations, see, here the specialist investigation only you are having the growth hormone provocation test. But the basic investigation will be trying to rule out the chronic kidney disease, thyroid, celiac disease, and if the child is a girl child, then karyotype. So these are the initial investigation. So try to rule out the celiac disease, try to do a karyotype, especially if the child is a girl child. Try to have your bone age. If at all you are interested in growth hormone, instead of growth hormone provocation test, you can go for IGF-1. So IGF-1 is a screening tool for growth hormone deficiency. So this order you try to follow. Okay. And here are some of the important types of short stature. So one is familial short stature. You know that in familial short stature, parents are also short, and the child actually falls within the mid-parental range. So whenever you calculate the mid-parental height and plus or minus 8 centimeter when you are putting, no, so they are falling within the predicted range of the parental height. Constitutional delay is someone where uh, there is a delay in puberty, bone age is slightly delayed, okay, and finally they catch up. So later, so we call them as the late bloomers. So late bloomers will have a family history. Either of the parents would have had a constitutional delay, okay. He will be short, bone age will be less, and but later on they catch up. So they are late bloomers. They have a delayed puberty, so they will catch up later on. So that is the constitutional delay. But they will not, their bone age will not be so much delayed. So here usually not more than 2 years. So whenever you have a delay in bone age more than 2 years, then that is significant. Okay. Then genetic syndromes, on looking at the syndromes, you can pick it up. But most important is this dictum, any girl child with short stature, you consider Turner syndrome. So you have to rule out Turner syndrome. Then other genetic syndromes based on the disproportionate, like your skeletal dysplasias. So whenever you have a disproportionate short stature like achondroplasia, you keep that. Then the nutritional. So in nutritional, you should understand like celiac, Crohn's disease, chronic kidney disease. the weight will be more affected. So here weight will be more affected than the height. So that you should understand. In endocrine, height will be more affected, bone age will be more affected, weight will not be that affected. In fact, they will be a bit plump. So the hypothyroid will have a weight gain. So they will be a bit more weight, but height will be more affected. Okay. Okay. So now it's a moving on to next question. It's a bit tricky. A 5-year-old child presents with hyponatremia 125. Given the following laboratory data, which of the following is the most likely diagnosis? So who wants to take? So here sodium is low, potassium is high, bicarbonate is low. Urinary sodium, we usually keep it as 20, so it's a bit high. So which condition is this? Which we get?
Sir, is it congenital adrenal hyperplasia?
Yeah, it is congenital adrenal hyperplasia. So how will you explain the electrolyte imbalance in congenital adrenal?
It is the hyponatremia occurs due to
Hyponatremia occurs because there is a salt wasting.
just a
Salt
question,
wasting.
salt. Yeah, the reabsorption is not occurring properly.
So salt
So-
wasting. So it's a phenomenon.
Mineralocorticoid and cortisol deficiencies.
So when that is there, you have the salt wasting. So the sodium will become low, and it is getting wasted through the urine. So that's why
Yes, sir.
urinary sodium is 50 and above. Okay, and we should understand that mineralocorticoid is one where sodium and potassium and hydrogen will go in the opposite direction. So sodium is low, potassium is high, and bicarbonate is low, which means the acidosis is there. So potassium and H plus are going in the opposite direction. It is only in one condition, that is the mineralocorticoid and the glucocorticoid. So the congenital adrenal hyperplasia is the most important DD here, where sodium and potassium are going in the opposite direction and H plus are going in the opposite direction. Okay, so like this, I will give you one more look into this second part. Are you able to see the underlined line?
Yes.
Okay, so can you tell this? No. So here sodium is low, potassium is low, but bicarbonate is elevated, which means alkalosis has happened.
Sir, this is pyloric stenosis.
Pyloric stenosis. Okay. So how you are saying this as pyloric stenosis?
Because sir, the hyponatremia, the chloride, it loses in due to vomiting. Hyponatremia is a part of pyloric stenosis. I do not remember the mechanism, sir.
Okay.
And alkalosis will be present. That also I remember, sir. Mechanism not remembering.
So,
That is
so
also.
here it is lost through the vomiting. The child is vomiting, so child is losing the chloride, child is losing the H plus. So that's why the alkalosis. So chloride is lost, alkalosis is there, and the child is losing along with that the sodium and potassium. But since it is being lost through the vomiting, the kidney will conserve the sodium. So that's why the urinary sodium is less than 20. So that is the important clue. So whenever the urinary sodium is less than 20, but the blood sodium is low, it means that it is being lost somewhere else. So that is because of the vomiting. Because of the vomiting, it is lost. Okay, so now there is one more scenario. So you look into this. Sodium is low, potassium is low, bicarbonate is elevated, and urinary sodium is more than 20. But urinary sodium is more than 20. So it is like
Sir, what is happening to chloride, sir? Is chloride is also elevated, no? Sir?
Chloride is
No.
not elevated, no?
No,
So
it
that is
is-
also being lost. So everything is getting lost.
Low. I mean, I think there is some. The answer is given, sir, but I think the mechanism is due to some reabsorption problem in the kidneys, which
Kidney.
causes.
Loss.
Yeah.
So it's like the
Hypochlorite metabolic alkalosis.
yeah. So it is like the Lasix. Like so when you give a Lasix, everything is getting lost through the kidney. No? So you look into the urinary sodium. Now it is more than 20. So something is getting lost through the kidney. So everything looks close, but when you look into the urinary sodium and look into the acidosis part, look whether sodium and potassium are going in the opposite direction, then you can make out what is happening. Okay. Then in the task question, very commonly they keep asking from which part of the body, which cell is coming. Okay. So ghrelin, so which is the correctly matched. So ghrelin antral cells of the stomach, somatostatin beta cells of pancreas, melatonin, insulin, leptin. So which one is correctly matched here?
Sir, not sure. Ghrelin is secreted from the GIT, I think, but whether it's from the antral cells, not sure, sir.
Okay, good. I think that is the right answer. And the somatostatin, doctor, it is from the delta cells.
Pituitary.
No. Somatostatin is from the pancreas only, but the delta cells. So you have alpha cell, glucagon, beta cells, insulin. There is something called the delta cells where the somatostatin comes. So I think these are all a bit we are not read much. So I think that's why reading the task book is very important. Theory and science book is very important because it's more of lot of factual things you have to remember. So melatonin is produced in the pineal gland, and leptin is produced in the adipose fatty tissue. So these are the important. Leptin is the adipocytes, melatonin is the pinealocyte, and ghrelin is the right answer. It is coming from the antral cells of the stomach. Remember, for pancreas, again and again, sometimes they keep asking. Alpha cell is the glucagon, beta cell is the insulin, and delta cell is the somatostatin. Okay. Okay. So this is a bit tricky. They have asked this question. So who wants to take this? A 5-year-old boy presents with height on the 90th centile, bone age of 9.5 years, large penis and testes, scanty pubic hair, normal blood pressure. What is the most likely cause? Who wants to take this?
Sir, I will just guess only, sir. 21 hydroxylase deficiency. Guess only.
Yeah.
Sorry, sir.
Yeah. So 21 hydroxylase deficiency in a 5-year-old boy. No? So 5-year-old boy means um, it's a congenital adrenal hyperplasia. No? What you're saying is congenital adrenal hyperplasia in a boy child. So the adrenal is producing more sex hormones.
Yeah.
So they will have a lot of adrenarche, most importantly. So they will have
Okay.
a lot of
So pubic hair.
here
Okay.
scanty pubic hair. Na? So here scanty.
Yeah. So it won't be there. That is true. Sir.
That is one. And most important. Okay. Anybody else wants to guess before we move on to?
GN excessive GNRI.
excessive GnRH. Na? So one important clue to that it is excessive GnRH is
Yeah.
testicles. So we said
Yeah.
that you can have hair, pubic hair, and anything when testosterone is there. So whenever testosterone is there, you can have a large penis. You can have hair, bone age growth. But testes will increase only when LH is coming from and stimulating. So you need the FSH. So only when the LH and FSH. So mainly the FSH. So it's a central precaution. So whenever you have a central precocious puberty, so then only the testicles will be enlarged. So it means that
Yeah.
it is coming from the center. But we should understand this flowchart. So whenever something comes from the center, it also should cause the adrenarche also. So
Yeah.
PTH gives the adrenarche, then LH gives the testes and testosterone. So gonadarche also happens. But here the adrenarche is not happening.
Not happening. Yes, sir. That is true.
Gonadarche is happening. It means that only the LH is stimulating. So it is not a central precocious puberty again. So it's a phenomenon where LH is alone stimulating, or probably the receptor is getting activated. So it is called
Yes, sir.
the
Yes, sir.
toxicosis. We have this
Yes, sir. Yes, sir.
activating. So it's a, but I still suddenly they're asking easier questions and suddenly some tough questions. So it's a case of testotoxicosis where the
Yes,
LH
sir.
receptor gets activated.
Yes, sir. That is
Okay. Okay. So now I think we have some short time. We will just do the questions instead of the discussion. You can just tell the answer. A diabetic child is found to be anti-GAD positive. What is the significance of this finding? So these are all now what we are discussing is the task questions. So it will be like factual. So you have to understand, then you will answer. FOP a bit easier. You have the clinical scenario, you have a background knowledge, so it helps you a lot. But TAS, you have to have the factual knowledge. Okay. So a diabetic child is found to be anti-GAD positive. What is the significance of this finding? To suggest that he has type 1 diabetes mellitus. So it's an autoimmune. So whenever autoimmune positive, so the GAD will get positive. So it's mainly to differentiate between the genetic causes of diabetes mellitus, that is maturity onset of diabetes, where the GAD will not be positive. Should remember the other antibodies which we discussed. So for Graves, it is TRAB. So you should remember that. Okay. So now it's a maybe I will finish off with the answers since in another 5 minutes we'll wrap it up. So he is a 12-year-old child with polyuria, polydipsia, weight loss. He is presenting with diabetes-like features. He is a known case of asthma on betamethasone. So he is on inhaled betamethasone. So now suddenly the sugar is 20, 20, 20 means 20 into 20, around 400. pH is decreased and bicarbonate is reduced. So it's a case of diabetic ketoacidosis. So now, what is the cause for the diabetic ketoacidosis? So we should understand that steroids can increase the sugar level, but it's unlikely that it's going to cause a diabetic ketoacidosis. So usually, whenever a child, even if the child is on steroid, presents with diabetic ketoacidosis, you should assume that it is because of the type 1 autoimmune destruction. So here the answer is autoimmune destruction of the beta cells of the pancreas. Okay. Then here, this I think we discussed already. So whenever you have a female child with short stature, always think in terms of Turner syndrome. So what is the investigation? It's going to be karyotyping. Okay. And this Turner syndrome and Klinefelter syndrome are two causes of hypogonadism. due to hypergonadotrophic. So here there is ovarian dysgenesis. So the GnRH will be stimulating more, LHFSH will be more. So it will be a hypergonadotrophic hypogonadism. Okay. Then all of the following contribute to hypokalemia in a patient with diabetic ketoacidosis except. So hypokalemia, so just remember for anything that causes, that is used in the treatment of hyperkalemia is going to cause hypokalemia. So that will be a very important clue. So we give soda bicarb to hyperkalemia, which means that alkalosis will cause hypokalemia. But here it is written metabolic acidosis, so that is wrong. So in metabolic acidosis, potassium will actually come out from the cells, and when you give soda bicarb, it pushes the potassium into the cells. So metabolic acidosis is a cause of hyperkalemia. So that's a important thing. Then what is the cause for cerebral edema in diabetic ketoacidosis? It is the sodium. We should understand that it is the rapid fall in sodium that is the cause for cerebral edema in diabetic ketoacidosis. So these are all they are asking in the TAS, all the questions like this. I think this you can all answer. It's a very nice, tricky question. So here is a child who is presenting with CAH-like features. Sodium is 133, potassium is 8, glucose is normal. So what is the next best step in management? Dr. Indra, can you tell this?
IV hydrocortisone.
Yeah, so I also was like thought of this. So that is the small trick they keep in FOP task so that get it wrong. So it's a case of CAH, right? Very good. So sodium is low and potassium, but and hydrocort is the treatment for congenital adrenal hyperplasia. Okay, but they have asked what is the next best step in management. So now, can you think? So what is the emergency here? Is there any emergency here?
Child in shock, sir.
Yeah, so that fluid's okay, but child's potassium. Look into the potassium.
Yes, sir. Yes, sir.
Yeah.
So,
So
calcium gluconate, sir.
So calcium gluconate. So that is the subtle thing which we should pick up. Had the potassium been 6, then the treatment will be IV hydrocortisone. But if the potassium is 8, so then the treatment will be calcium gluconate. So that is how they trick us. Okay. Then this, I think, straightforward polyuria, polydipsia. Investigation revealed that there is a defect in the V2 receptor in the kidney, which means that it is the nephrogenic diabetes insipidus. Okay. Then a 3-week-old neonate screening reveals the high TSH. Then they did the radioisotope scan, which shows no uptake. There is no uptake, radioisotope scan. Even in ultrasound, the thyroid tissue is not there. Then what is the most likely reason? So most likely reason is the thyroid agenesis. So the thyroid agenesis is the commonest cause of hypothyroidism. Next common will be the ectopic. So the thyroid, instead of descending, there might be ectopic in some place. So thyroid agenesis, thyroid ectopic. Okay, so then this again, I think Dr. Indra, you can attempt this. A bit tricky. 7-year-old boy on desmopressin. So for nocturnal enuresis, you are giving desmopressin. We know that desmopressin causes hyponatremia and it can cause seizures. Now the child presented with seizures. Child has lethargy, vomiting, and abdominal pain. His investigation revealed this. Sodium is low, potassium is high, glucose is low. So what is the most likely diagnosis, doctor? Can we say that it is desmopressin overdose? Dr. Indra, Dr. AKK.
Adrenal insufficiency, Addison's disease, sir.
Yeah, Addison's disease. Very good. So, even though desmopressin is known to cause hyponatremia, so here serum sodium is low, actually hyponatremia. So it will be very easy to explain that desmopressin is the cause for the seizure. But why? What made you think it as adrenal insufficiency, doctor? So it's the Dr. Indra. What made you?
Sir, along with lethargy, vomitings, abdominal pain, blood glucose is also low, sir.
Yeah, blood glucose is low and potassium.
Potassium is high.
potassium is high, sir. High.
Potassium is going in the opposite direction. So
Opposite
whenever
direction.
sodium and potassium are going in the opposite direction, mineralocorticoid, plus
And
you have a glucose also low. So glucocorticoid is also low. So I think
cortisol.
the overall adrenal is damaged. So it's the Addison's disease. Okay. So that's a good. Okay. So then regarding insulin, types of insulin, they keep asking about the types of insulin in the TAS. So what type of insulin is used in continuous subcutaneous insulin pump? So you should understand that we use only the short acting type in the rapid acting type in the pumps. Okay. So insulin aspartate is only added. It's not the long acting glargine, isophane, etc. Then there was also a scenario of which has the longest duration of action. So these are all the task question. So for that we need to know the tabular column. So read it in the Lizard's illustrated textbook of pediatrics. So in that it is clearly written which one has the longest duration, which one has the shortest duration. So Diglutec has the longest duration. So that is the clue. So rapid acting, Lispro and Glulicin and aspartate are all rapid acting insulins. Okay. So like this also they often ask what is the primary mechanism of action of insulin. So in a diabetic child, what is the main mechanism? So it is the conversion of glucose 6-phosphate. So what insulin does is it opens up the GLUT4 channel, it promotes the GLUT4 channel, and then glucose enters inside and glucose gets converted to glucose 6-phosphate. So it gets trapped. So insulin's role is to trap the glucose intracellularly by converting it into glucose 6-phosphate by the hexokinase or glucokinase enzyme. So like this they ask in the task. So they go into the pathophysiology, etc. Then this is the final question for the day. Okay. So many times they give you like this table of a child with different sugar levels and the insulin level, what insulin their child is taking. Then they will ask you which needs to get adjusted. So which all insulin we need to adjust. So in that we should remember that early morning insulin reflects the basal insulin. Similarly, the pre-meal insulin always reflects the basal insulin. So you have to increase the Lantus or whatever the long-acting insulin which is going on. If the early morning insulin is high, so whenever you have a child's early morning insulin is high, then you have to adjust the long-acting insulin. For rapid-acting insulin or the short-acting insulin, after the after the meals, 2 hours after the meals, whichever sugar you are looking, if it is high, then you have to adjust that short acting insulin. So this is the basic principle. So Dr. Last question for you, Dr. Indra. So your morning sugar is high. So what are you going to do? What will be your next immediate step? if your morning sugar is high.
We'll try to increase the long-acting insulin dosage.
Yeah. So, Dr. AKK.
Sir, same answer, sir. Increase the long-acting insulin.
Yeah. So that is a small trick in that. So you have to understand the Somogi phenomenon. You are aware, I think, no? The Somogi phenomenon. So suppose the insulin is high already. So what will it cause in the night? It will cause
Hypoglycemia.
glycemia. Then you will have a rebound hyperglycemia. So the first step when you have a hyperglycemia in the morning is to look into the midnight sugars. Okay, so you look into the midnight sugars. If the midnight sugar is also high, then you are going to increase the long acting insulin. If the midnight sugar is low hypoglycemic level, then you have to reduce down the dose. So that will be the small trap they will keep. So they will put like sugar is high. What will be you doing? So in that one small benign answer will be there. I will look into the midnight sugar. Then there will be I will increase the short acting. I will increase the long acting. Then we might be tempted to choose the long acting insulin to increase. But we should understand that we need to know what is happening in the midnight before deciding on the increasing the long acting. Okay. Okay, doctor. So hope it was useful.
Sir, in this case, is the midnight value given, sir?
Yeah, I think this is an incomplete scenario actually.
Probably, yes, sir. Yes, sir. Yes, sir. I understand.
In a complete, I think in Lizar's there is a very nice chart. The whole chart is there. So in that in night it goes to 4 actually. So then
Okay.
in case that we have to increase the dose of the glargine like that. Okay, doctor.
Sir, due to duty, could not attend fully. So,
We
is
will,
this session going to be repeated, or is it available online or something like that, sir?
yeah, I will upload it in YouTube, doctor. Okay.
Okay, sir.
What
And,
I will
sir,
do is I will share my number in the group chat. You can note down.
sir.
If you have difficulty in joining the WhatsApp group, you can message me. Okay. And YouTube links. Message. Do you just note it down? Okay.
Yes, sir. I got it.
I will share you if you have not joined already the group. Actually, we are planning to do the recalls. So,
Sir, regarding joining, sir, usually, yes.
tell doctor. Yeah. So you can message me. I will share you the
Such a better.
group link, and once you
Okay.
join the group, the recorded videos we will share in the YouTube. So we'll share the links so that you can revise it. Okay. And maybe next week we will try to do cardiology some questions. Okay.
Sir, can I ask a question, sir?
Yeah, doctor. Yeah.
Sir, right now, these sessions are meant for candidates who are planning to attend the next examination, like that only. Isn't it, sir? But
Yeah.
I have just started preparation only, and I don't have an exact idea when I'm going to write and answer. Actually, so in that way, I'm actually not properly mentored or guided, actually. So what I found was that doing these MCQs will really tell that whether I will be able to do this or not. And so in that case, I was planning to just to do the more and more MCQs so that when I get the confidence of attending the examination, then I will get registered and go forward appropriately. Is that a good idea, or what exactly should I do, sir? What is the best thing for me?
Actually, I feel that your knowledge is good, doctor. So
Right.
You can take 3 months time. You are now working where, doctor? As a you're working as
I'm not. I'm actually in South India, Kerala only. But right now I am trying for a job in Middle East, and now I am working right now there. But the formalities are not over. But probably I will return or after 3 or 4 months. I will be planning seriously to give this examination anyway, sir. That is what. So in 3 months, my decision will be taken whether I will be coming back to India or.
pediatrician, doctor. You're a pediatrician.
Yes, sir. I am a pediatrician only, sir.
Okay. That's what, doctor. Your basic knowledge is there. You're a pediatrician. I think 3 months is good enough time. So
Okay, sir. In that case, which month examination should I plan to appear for, sir?
when is the next? Did you check, doctor? Next day, FOP TAS exam dates. 1 minute, doctor. I'll check. Actually, you look into 3 months time, no? Upcoming exams. June. So application.
Sir, one more question. After June, which is the next
June.
time, sir? Will the next exam come after 3 months?
Yeah. So next window is June, doctor, for you. So
Okay. After that, it will be January, no?
no. After that, actually, October also you have one. Actually.
October. Okay.
So 3 times it comes actually.
Okay.
So
Okay.
June is the next window. So April you have to apply.
Mm-hmm.
So my suggestion is maybe you can take one at a time. Also, you can take a
Yes. Yes.
separately
Yes.
or together
Sir,
also.
for appearing for the task, how much should I spend, sir, for money like that?
Exams, huh?
Yes, sir. I mean, for appearing for the task, should I?
Actually, each exam is around 60,000, 70,000.
Yes. Sir, do you have a paid course like that actually? Because I understand that I just joined from the IFA group in this group, and sir is giving good classes for me. So I was just wondering, most of these people will take fees and then only give the study materials and classes like that only. So is that happening with you also, sir, or are you continuing with this? Or
we are more of we are actually doing more of clinical classes actually. At present, we are regularly doing MRCPCH clinical part, third part.
Okay.
This part we are planning to do more of recalls. So
Okay.
we will do you
For
all
the
the
examination.
yeah
Okay.
recall papers, 5 years recall papers. So like 10 plus 10, 20 papers we are planning. Maybe you can join us as a whole. So once we do the papers.
So you have a course to offer, sir, where I can, where I should give some fees and join like that?
Yeah, you message doctor.
So
we will guide you.
okay, fine. Thank you so much, sir. I will be messaging, sir. Thank you for it. Was very, it was different from many other classes I have YouTube attended. Sir is very precise, and you are just mentioning only what is needed, and that is very important. And the explanation is also very authentic and nice slides also. Good night, sir. Thank you so much.
Thank you.